Hello everyone, welcome to all the attendees for this first Corona Café. The Corona Café is a joint partnership between the Alliance Masese Nairobi, IFRA and the Elephant. So with this series of Corona Cafés, we will be exploring or rather reimagining Kenya across a number of issues. And the first Corona Café today is going to be looking at the healthcare systems. So here's a warm welcome to all the attendees and to our moderator and the panelists. So I will now pass you over to Dr. Mshai Mwangola, who's going to be moderating all the Corona Cafés, and we'll start off with the one on healthcare systems. Thank you. Welcome, Mshai. Welcome, panelists.
Thank you very much, Asita, and welcome to everybody. It is such a pleasure to bring the first of our Corona Cafés. As Asita has said, it is a pleasure to be here hosted by the three bodies, IFRA, Alliance Française, and the Elephant. And in this series of 4 cafes, we will be looking at a number of questions that have come up, not so much focusing on the details of the pandemic and what it means. I think we've had lots of conversations about that. But we want to use this space that we have been thrust into as a place to reimagine the future. We want to ask ourselves if it is possible from the space where we are today to indeed begin to reflect on how we might exit this, this present into a future that makes the pain and the everything that we've been in through worth it. So as we look at this new turning point, we thought it would be important to start by actually thinking critically about our health systems, because I think we're here because of the health systems. We know that we have seen the way our own health systems here in Kenya have been robustly challenged by this pandemic. And we wanted to think through what it is we might do to put in place a robust healthcare system by asking ourselves, what are the responses, what are the interventions, what are the challenges that the COVID-19 has helped amplify for our system? And to do that with us today, we have a really able panel. I'm going to introduce them in a few minutes. The panel, we are going to be looking and starting with Dr. Richard Eyre. Dr. Richard Eyre holds both a PhD in public health, as well as he is a medical doctor himself. Dr. Ayah is the director of the University of Nairobi's Science and Technology Park, and he is a senior lecturer in health policy and health systems at the School of Public Health at the University of Nairobi. Dr. Ayah, I want to give you a chance to just come on board and say good evening to everybody. But as you do so, I just wondered if you could say a little bit on what does it mean when you say you're at the School of Public Health? Because I'm assuming when you talk about health, we're always talking about public health, no? So what does it mean when you say that you're a specialist in public health? Karibu.
Yeah, Asante. Thanks, Mshai. Good evening, everyone. So I'm at the School of Public Health. I've been there for a number of years, and I know that people tend to think about health as one whole thing and think about everything as public health. But within the College of Health Science at the University of Nairobi, there's the clinical side, the School of Medicine, and then there is the public health side. And public health essentially deals with both the preventive and promotive aspects of health. And in my area, we also talk about from policy. So setting health policy, looking at the money and how the whole health system is organized.
Thank you. So when we're looking at COVID, and I'll come to you in a few minutes, then what have we learned about that? Thank you very much, and you're very welcome, Richard. I also then want to introduce Dr. Nelly Bosire. I don't know if I should use the term introduce, because I think you're somebody who's really done a lot of work in the public sphere. I think you're a familiar name to many of us. You are a medical doctor, and I know you are a practicing obstetrician gynecologist. But I think the place that you're very familiar, most of us know you from, is that you have been an advocate for this field of health. You're very passionate about medical education and helping us think through in the public sphere what it means in detail. I know, Dr. Bosire, that you are familiar to many because you have done a lot of work with the KPMDU. I think that's where many of us first got to hear your name, and that you are a former board member and currently a disciplinary committee member of the Medical Practitioners and Dentists Council, and that you also sit on the Health Advisory Board as the chair of that board of the St. Francis Community Hospital. In asking you to just welcoming you onto the panel and introducing yourself, tell me why you're so passionate about medical education. Why are you so passionate about writing and speaking out in the public sphere? Why do you think it's important?
Thank you, Dr. Mshai. It's a pleasure to be here. And as you say, why am I so passionate about this? It's because all of us, we're a step away from being patients. All of us, we're a step away from being the one on that bed. There is no guarantee. There is nothing that ensures a person from being a potential patient. And so where I sit, when I look at it from that perspective, then my question is, if I were a patient today, what do I want? When I'm talking about quality healthcare, I mean, it starts with the provider. Are they well trained? Are they qualified? Are we releasing people to the unsuspecting public who actually know what they're doing? And hence the passion in medical education. And I always say that patients, when you're a patient, you're really at your most vulnerable. And this is the one time you're 100% dependent on somebody else to take care of you. You are exposed. And if anything could be done to protect you in that state of vulnerability, then I'm definitely very willing to make that happen.
Thank you, Dr. Bosire. And I'm really pleased to have you because so many people are afraid of going into a doctor's surgery, going to the hospital. And it's great when you have somebody who's out there demystifying all of that. So karibu sana. And then it is also such a pleasure to welcome Dr. Eric Masese. Dr. Eric Masese is a medical sociologist in the Department of Sociology, Psychology, and Anthropology at Moi University. Dr. Masese is very invested in understanding how our lived experience as human beings affects our health. And I had a lot of, I found his discussion of this with regard to HIV/AIDS to be absolutely fascinating. But Dr. Masese, when we talk of medical sociologists, it's a term that many of us are not at all familiar with. What exactly does a medical sociologist do?
Thank you so much. As medical sociologists, we know medicine deals with diseases, with pathogens. As we try to understand how people are the center in the medical practices. For instance, why do people, if you are going, we have normally had this conversation that every person goes to hospital with an illness. And when he comes out, he comes then talking about is that our health is beyond pathogens. It's more to deal with our socialization, our environment, and how we define what health is, not just a mere absence of illness, but more to do with what the society defines as well-being. For medical sociologists, we normally look at health beyond pathogens, and we look at more into what is the social well-being of a person. And this is relative from one place to another, from one community to another. Thank you.
Aha. So now then I'm going to come to all three of you. Karibuni sana. What have we then learned? Just very briefly, looking at what COVID-19 has brought us in this season, in the last 2 months, what is it that we have learned? What is it that it has told us about our health systems? I know we can say a lot about the past, where we've come from, but right now, what for you is the big thing that we seem to be seeing, and it's a big lesson that you would want us, if there are two or three things that you think is critical for us to understand. Dr. Bosire, may I start with you, please?
Sure. I think there is nothing as great as having your nakedness exposed, because then it makes you realize you need to dress up. And if one thing we have really learned is we've been able to really see the weaknesses of our systems. But for me, what is so encouraging is that we have actually been able to see that we have the capacity to actually power our health system to be what it needs to be without the intervention of anyone else except us. We have seen the capacity to manufacture. We have seen our manufacturing companies that had actually stopped producing some of these items we are now using in the health sector suddenly rev up and be able to manufacture quality masks. We have seen our universities wake up, and all of a sudden now they're actually able to innovate and give us medical products that we didn't need to import anymore. And we have also taught our people that we can have faith in our own systems if we invest in them. So people are unable to go out of the country to seek medical care, but we have taken care of our own right here. And I hope that this is building a sense of confidence in the public, in our own public health system, and further giving all of us an opportunity to demand for the best simply because we can. Because in as much as providers, we see the gaps and we can keep raising these and speaking up at it, there's nothing as powerful as when the end user demands of their government to actually put in place a proper, robust, functional health system. For me, this has been the biggest lesson in learning from COVID, and I'm hoping that we don't lose this lesson, because if we keep up the spirit with which we started, then we really will take the healthcare of this country places.
Wow, that's absolutely interesting, because the three things that I'm picking from you is that the whole question of self-reliance. And for me, that's so fascinating, coming from yesterday being Madaraka Day, and about taking responsibility, both from the thinking out, not being able to rely on what other people would tell us to do, being able to start to ask within our own manufacturing industry, what is it that we are able to do, being able to begin to figure out and to say, if I can't go abroad, if I get sick, then I better have a working and robust health system. And so those are three of the things that then perhaps we will come back to later on as we think about, so how do we make sure that this isn't just things we're waking up to, but we actually make them a reality. Dr. Ayah, what is it that the 2 or 3 things that you think COVID-19 has really brought up to us?
I think one of them, Dr. Bosire is quite rightly quite positive. I think one of them is that we have some quite good guys at MOH. I was looking at my diary on 30th, around that week of 30th January, and it looked just as usual. So the announcement of that there's a pandemic declared by WHO, I think just sort of passed by. But I look at the bulletins of MOH, and they did release a statement as early as 2nd February saying there was something going on and that we needed to start taking care. So that to me was something that struck me, that we do have some very good professionals around. The flip side of that is that after that, and I think this is something that is probably global because everybody's looking for answers, is we have, people talk about it, but for it to really come out, is the low levels of trust that we have in our society, particularly amongst institutions, particularly government. So at some point, I think we should have had a situation where we admit that we're really struggling to mobilize after that. So there's a big gap when we really didn't know what to do. And there's an early strategy done by MOH, and it's not a very nice document, because in the bit about mobilization, it said we look to donors in case this thing grows. And it was a 3-month plan. So that for me was something that struck me, that we're so reliant on donors thinking for us. And this particular pandemic, I think, has brought out the issue that every country is kind of on its own. So we have to think for ourselves and do stuff for ourselves. I think that is a real awakening for me. Yeah.
Thank you very much. And again, I mean, so again, the question of self-reliance, and I think you bring up a very important point, that Kenya tends to rely a lot in the area of health. We look at donors. We've got, it's one of the areas where we have such a heavy donor dependency, and there are implications for that. And in a situation where every country is struggling and looking inward, first of all, then we do have a big issue there. And the second issue that to bring up is the whole state of disaster preparedness. I know I've had so many people say that we couldn't have seen the pandemic coming. And one of the things I have learned is actually there are many people who had predicted a pandemic was going to come sooner rather than later, or some kind of a health crisis. And the fact that, as you know, it's interesting when you say February 2nd, I'm thinking, wow, most of us had no idea that this was coming at that point, and it would hit home. So it's really interesting that you raised that point. Dr. Masese, I know you don't look at, come to this so much from the medical point of view. What are some of the things that strike you that COVID-19 has revealed for us?
I think for me, COVID is a blessing in disguise for us as Kenyans and the world over. First of all, it has made us now to think health before wealth. And this has now changed the definition of what health means for us. For instance, is health means the absence of disease? Does health mean absence of illness? Does health mean absence of disease and illness? When you look at these three questions, and in relation to COVID, they ask to us, what does health mean to us? We need to define what health means. For instance, if you look at COVID is not just absence of pathogens. It's more to deal with our social well-being. And when you deal with our social well-being, it is a way of, we need to engineer our healthcare system, not only to focus on the disease, but also to focus on the social well-being of the people. In this case, by focusing on the social well-being of the people, this COVID has acted as a mirror to us Kenyans, or as human beings. It has defined us who we are, what is our relationship to each other, and what is our relationship within our environment. This because this COVID is not spreading randomly. It's following the natures within our society, the inequalities. So it's exposing in a way, what are our priorities as a people? Do we continue dealing with pathogens, or are we empowering communities to have resilience? Do we need to care ourselves individualized kind of health systems, or we need to go to an holistic kind of health systems? Also, it has brought us into aspect that because COVID is not affecting only specific group of people, it's affecting the poor, the rich. It has made us now to realize that the Ubuntu philosophy is very important in our society, because even if you are having first-class medical systems, but poor people are there, it becomes a problem to you. Also, it's now coming out, what are our values? We must inculcate our values in our health system, because what we are experiencing now about the mitigating factor, the mitigating strategies we are imposing, we are now adhering, the government's coming up with, they are all affected by our value system. So this thing is important for us. And actually, by looking at the COVID, also ask questions. How do we finance our health systems? Do we need big infrastructure? Do we need big institutions? And the answer is simple. We need simple things to learn we need only to invest on people the way we are investing on washing hands. It's simple. We don't need big hospitals. We need small things. Thank you.
And so what you're then emphasizing is that we need to pay attention to the software issues. A lot of times when we talk about health, we talk about we need to spend money building. We need to look at infrastructure. And you're saying, actually, the thing that Dr. Ayah pointed to, we need to build trust. We need to remember that we're working with human beings. And we need to ask what the implications of all of that are. And okay, so these are the things, some of the things that COVID-19 is telling us we need to pay attention to. So I'm going to come to each one of you, and I'm going to give you a minute, 2 minutes each. If tomorrow you were to be granted your desire, all the resources that Kenya has to spend in the health sector is going to be spent on making your wish come true. What is the image? What is it that you would like to imagine? What's the future that, 2050, let me say 2050, you're retiring, and Dr. Ayah, you're retiring, and we are excited. The University of Nairobi has thrown a big party, and they're saying that this man has changed Kenya because of the vision that he had for our health sector. What would that vision be?
You put so many things in there, retirement and what, and so on.
I want you to think of your grandchildren in the front row listening to you, 2050.
Yeah. I think actually I think some of the things, it's quite modest. If you're sitting looking back, one of them is that our highest level referral hospitals have built a presidential wing. So having that, whether it's in MTRH or in KNH or at Coast General, if we now no longer send people abroad and we're able to protect our top leaders with good healthcare in our public institutions, then I'd be very happy, because then we would have shown that we've built a good system. So for me, that would be one thing. The other one is that we currently have a very lopsided system in two ways. One is that 2/3 of our health workers are in the private sector. And one of the weaknesses that has been shown now is that this is a public health problem, and we're dealing with it with very few, all the resources are sitting in the private sector and not in the public sector. So people complain and say, oh gosh, my insurance didn't cover and so on. It wouldn't, because this is a public health problem. So expanding the public health sector all the way from the the public health schools in terms of public health education would be one thing. The day we see, this is 2050 or 2049, when we have a lot more health workers on the public health side. And the way I would know that is when a public health worker visits my house and I know the person by name, and vice versa. And they're not coming to take me away to quarantine or anything like that. They're just paying a visit to check on my health. Then I know that we have a system that is working. I think the third one is it requires a bit of explanation, but I'll not give it. And that is that at that point, we have abolished private wings in all the public hospitals, so that we have a system of basically equality. Yeah? Mm-hmm. So we've got a system almost of apartheid, where we keep on trying to create little enclaves and keep on dividing people. So you say, okay, you're ordinary, but we're doing policy. Well, I'm part of that group that does policy. But you end up saying it is policy for them rather than policy for us. So policy for us we should all be included in all this. I guess I wasn't quite involved in the decision, but I was born in Kenyatta Hospital. Mm-hmm. And I reckon I'll probably end up spending time there at some point. So really that is what it should be. So we shouldn't have a private wing and all these little bits that people try to claim privilege. The service should be one that is good enough for everybody.
Oh. So if I may rephrase that, you're saying our top priority would be to create this unified health system that serves everybody and serves everybody regardless of your class, regardless of your geographical or social, any kind of location. regardless of whether you work for the state and you're the president of the Republic of Kenya, or you are somebody who lives in the furthest, I'm going to think of what is the furthest from Nairobi County, and you live off the land. All of us will have access to this quality healthcare system, and that there is a sense of intimacy. Your community health worker will know how to find you and how to be able to work with you. Have I summarized that more or less, brought it together?
More or less, except that I think that the president is special. The president, you can give a little bit higher, but everyone else.
This would be happening in a public health setting.
Yes, such that if you want to go to a private hospital, it is really choice, not that something is lacking.
Yes.
Yeah.
Not because if I go to the public healthcare system, I don't think I'll get the care that I want and I need. Thank you very much. I'm going to come back to you and ask you, okay, so how do we get from where we are and where you want to take us? And remember, we have 30 years to get to your dream. So you can give me the points of what we need to do, or whatever you're going to do by the time you retire and we celebrate you. And one of the things, it's such a joy. I'm happy to see that we do have quite a number of people, about 40 people who are in this chat with us. And we also have some people who are on YouTube. Please, if you are one of the participants, I'm going to be coming to you in a few minutes. Feel free to start putting your questions on chat so that by the time I get Dr. Bosire and Dr. Masese's visions and we hear a little bit more about how they want us to get there, I will come to your questions on chat. Dr. Masese, take me to your dream. You have been invited at the end by 2050. You have been invited to the United Nations. And again, you are giving an address and everybody is saying, Kenya is the country to emulate. Look at where they were in 2020. They were with us. But now in 2050, everybody wants to go to Kenya. Everybody wants to be a Kenyan because of the healthcare system. What do you think we would have done that would have completely transformed our healthcare system?
I don't think we don't need sophisticated policies. We need simple things to make our health system to be better. And from the experience of
what we need, what's your vision? What would the vision of that place be?
An holistic healthcare systems.
Okay.
An holistic care system, health system, which deals with both the welfare of the people and which deals with cumulative. In this case, for me, I would like to see an health system which is more preventive oriented than curative oriented. And the reason why I'm saying that, if you look at the experience from COVID, and you have been seeing the social media, that most hospitals, which are the more specialized on curative, are complaining that they don't have patients, simply because people have adopted simple basic hygiene. People have been involved in their health. And that has helped us a lot to minimize the cost of illness or disease in this country. And this has implications in terms of our financing of our health system. If you look at the universal health care, and we thank the government for it, like now the introduction of NHIF for patients, which has been more paying money for curative. You have seen now, when we have implemented these simple basic things, most people are not going there. So that means our financing of healthcare system in Kenya should not go to curative, but should go to prevention. Once we do prevention, the cost of healthcare in Kenya will go down. And this has implication on our health system. We have been having contestation between the national government and the county government. And if you look at these two actors, you will realize that they are overlapping. For me, this COVID has given us a good opportunity to come up with a healthcare system which is two-tier. the devolution, the county governments will not deal with curative, but they will deal more with prevention, because prevention depends on people's way of life.
Okay.
Like if you tell people social distance, if you tell them their mother tongue and explain them using examples from their context, they can easily accept and they can adhere it. So we can, the county governments will deal with prevention, the national governments will deal with curative. In this way, we will have a system where we have bottom-up innovation from the county government and top-bottom from the national government. And that will make our health system very okay.
So when we look at then the health system, it is holistic in every sense of the word, both in terms of the structure of it and who's serving what at which point, but also to look at health not simply from the medical point of view, the clinical point of view, but asking what does it take to make a human being a healthy person and to make sure that we're catering for all of those needs. Thank you. Again, I'll also come back to you and say, what are the simple things that we need to get there? But Dr. Bosire, as you receive the Nobel Prize, you can have it in medicine or you can have it in peace. That's up to you to decide. In 2050, what would your speech address as the thing that you have invested your life that has transformed health for us?
I think I would combine both what Dr. Ayah and Dr. Masese are saying. My focus is on an actual functional delivering primary healthcare system. I want this child who is born in Turkana to have a medical record from the day they are born to the day they die, and somebody who knows them personally. I want this child to have a pediatrician, at least until the age of 13, who has walked the childhood journey with them, who knows what their vaccination record looks like, who knows what allergies they have, who knows what nutritional challenges they've had at whatever age. Transition into a teenager who is transitioning into physician care or primary healthcare physician care, who again walks this journey with them, who can tell at which point they got diabetic at the age of 67, at which point what cancer have they survived along the way, and at the point when they die, somebody who understands them. We don't have this, and this is what has made Cuban healthcare system extremely successful. And for that, what happens is that it makes care cheap, it makes care affordable, it makes care accessible, and focuses a lot on preventive health. It's very disheartening when I see a woman for the first time in my clinic when she's 6 months pregnant. And when I ask her if this is her first visit to a gynecologist, she's like, yes, now I'm pregnant, now I'm here. And I'm asking, what's happening to gynecological care from the time you became a woman in teenage? So we've had a lot of care become curative because, as Dr. Masese said, we lost the focus on preventive. But I'd also like to say that it takes both to actually attain preventive care. If I'm taking good care of a baby from childhood, I'm preventing development of complications. I am averting unnecessary malnutrition. I am averting unnecessary obesity, which is becoming a real issue with us. And we don't have that in the system. We don't even have a centralized health information system. So today, if I wake up at night and I have a sore throat, I go to a private hospital in Nairobi, I am seen and I'm given medication and I go home. And if my fever doesn't improve, tomorrow I go to a different private provider who gives me a different antibiotic. They have no idea how I looked like yesterday. They don't even know what prescription I was given yesterday. And so they may end up giving me a different antibiotic, which is exactly the same as I was given, just bearing a different name, waste of resources, and has actually not taken care of me. So if we could achieve a proper centralized health information system where anytime I check into any provider's care, they just log in my unique identifier, it brings up all my record from childhood, and they can pick up where they left off, they can see what tests have been done, they can see what I have been treated for in the last all my life, and there is consistency and continuity of care. It will not matter where I am. And the care providers then can be able to ensure quality of care through and through, because you can't drop the ball knowing that tomorrow the other person seeing this person's record can see how you messed up last time. It also holds people to account. And I think if we can achieve that, for me, I will be good. We will have actually done everything, because we would have been the people giving monitoring and evaluation on quality. And for that case, because people know they're consistently being monitored, they can actually sustain quality care.
Excellent. And I'm really happy that you all seem to be in agreement. You may be emphasizing slightly different things, but you're in agreement. So before I go to the questions, I'm going to ask each of you to say no more than 3 things that we can do, because I know it is possible for us to break down what needs to be done to achieve these dreams into maybe 10 or 15, 20 different things that need to be done. And that's the kind of thing that people then just say, wow, that's so overwhelming, we can't do it. But if you can tell me the 1, 2, 3 things that for you, if we did this, we would be realizing your vision, what would they be? Just 3 very brief things before we go to the questions. Dr. Masese, why don't you start us off this time?
Thank you so much. And 3 simple things I said. 1, maybe we can start with the training of medical personnel. I think we should change our pedagogy of training our medical personnel. For example, instead of, we should emphasize more on community problem-based kind of training, where our medicals should be trained to deal with the problem in the community, not about the diseases.
Okay, so the first one is pedagogy.
Pedagogy. The second one is healthy financing. Is also very important. I think from COVID, we have learned that we don't need to depend on donor funding. I've seen the government has mobilized resources locally. If we can go for local financing, we can achieve good healthcare systems. Excellent. I think during the HIV/AIDS time, we lost this opportunity because we depended more on donor funding. And you know, donor funding comes with conditionalities.
Yes.
So if we can start now domestic funding. Yeah. Another thing which may look simple, but very important, our healthcare systems should be gendered.
Okay.
From what we have seen, gendering of healthcare systems is very important. From what we have seen from COVID, we have seen more men infected with COVID. Unlike in HIV/AIDS, more women were infected. Right. But the burden of COVID, the people who are bearing the burden of COVID are the women through domestic violence.
Okay.
So in this case, we should ask ourselves, how do we make our healthcare system gender sensitive?
That's
and the last 3, and the last 3, and the last 3 also, we should think about moving away from social support systems. We have seen that COVID requires not individual precautions or individual efforts, but it requires collective efforts. And these collective efforts need to be contextualized. We must take the society into it. For instance, what you have seen like now, what the government has done in Kibera, what they have said, like this cleaning of Kibera, where they're using the local people and giving them funding. And you have seen people are now doing better. You have seen people disobeying the government. They have made COVID to be a secondary problem because of the immediate structural factors. So as we deal with health issues, we should also deal with structural impediments to good health. Thank you.
Thank you very much. So pedagogy, health financing, gendering our health systems, and then making it, thinking about the social structure that the health has to be dealt in with. Thank you very much. Dr. Bosire, what are the steps that we would need to pay attention to?
Well, importantly is communication. People cannot do what they do not understand. And I think we need to disabuse this notion where we think that just because somebody is not a healthcare professional or is not very learned, that they have no capacity to understand issues of health and disease. We must find a way to break it down to the simplest language that even my 94-year-old grandmother can understand. And it is possible. And if we can then continue to continually educate, then we empower these people to start making choices for themselves. For decades, our healthcare system has been centered on the doctor says, the patient does. And we have to change this narrative. We have to empower the patient and the person who is in the community who is seeking help to actually take decisions for themselves because they understand, and that makes them partners in their own care, which means that they are more likely to comply and they are more likely to drive a healthy society more than we can ever hope to do from the point of decision making, policy making, or curative service provision. The second thing, we must stop wastage. We have to stop wastage. To be honest, healthcare is not cheap, and that's something we have to own up to. Healthcare is extremely expensive, and so we have to make the best possible, most effective use of the resources that we have for the best possible outcomes. We haven't seen this in this country for a long time. There's been a lot of corruption and wastage in the people who are handling our healthcare resources. We have so much that we can do a lot with. We aren't even doing enough with what we have before we even start asking for donor funding. So on the aspect of healthcare financing, it's not just how much resources we put in, but how effectively we use what we have. And this then informs the kinds of decision-making processes that we're taking. We're talking about how do we educate the healthcare providers. However, I am going to take a step back and look at how are we distributing resource allocation in the training of the healthcare workers we have. I will use the example of clinical officers. We have nearly 20,000 registered clinical officers in this country. We haven't even employed 8,000 of them. So why are we still training them if we don't intend to use them? And this is tricky because the biggest employer of healthcare workers has always been government. So when government becomes the first one to not employ, but it's busy pumping resources and constructing an MTC in every village to continue churning out health workers who they are not using, that's a waste of resources. We need to focus, come back to the drawing board, decide who do we need, how do we grow that number, what projections do we have, because our use of resources, especially human resources for health, starts all the way back there. We don't do any projections. And then we're now training all these healthcare workers who we don't want to utilize. We're happy to put resources in training. We're not happy to put resources to sustain them. So we end up losing more than 30% of people we have invested so much to train to countries that will receive them with open arms, make the best use of their skills, have a much better healthcare system. And we are then left here crying that we don't have a functional system. For me, that would be important. The projections, the planning, the effective use of the resources that we have can actually give us what we need.
How excellent. So the question of communication and then really thinking through the question of strategy, both in terms of resource, getting a really good resource strategy, both in terms of what comes in, how we use the resources that we have to be able to make sure that even our human resources are at the optimum. We have a judicious use of the resources that we have. Those are really excellent points. Dr. Ayah, what magic wand do we have? The three things we'll pay attention to.
Okay, so first, I think we should write a letter to whoever receives these applications that we apply to be a low-income country again, and we move away from being a middle-income country, because it's affecting our health finances in a big way. So if we could do that, I think it would help us, because one of the tragedies that's been emerging is that as a low-income country, we receive grants for health. We don't have to pay it back. As a middle-income country, we're no longer eligible for a lot of grants, and now we have to borrow money. We've been borrowing money, and we've been doing stuff like buying medical equipment, high-end and scanners and so on. So the budget for promotive health has been stuck at more or less 10, 11% for years and years. It doesn't go up. So part of it is if we can do that, then the second bit is that we need to entrench devolution and make governors accountable for health. Health it starts off by being an individual thing, as we know the definition, and then it becomes a community thing in the sense of how the environment interacts with our personal health. And that environment is both from a policy perspective and the actual environment, we think about the physical. I was reading an address, looking at stuff around 1963, and this was an address by the president of the tropical medicine group in the UK. And one of the things he said was that medicine had shifted. And this concept, I mean, in the UK and all that, this concept of teaching tropical medicine, what they now call global health, and the same kind of health public health that we teach here. And all it is, and he said at that time that all tropical medicine was disease moving out of the doctor's clinic and interacting with the environment. And therefore, the doctor was supposed to be somebody who worked with the biologist and worked with people in the environment and science in order to manage disease. So it's not just a question of waiting for somebody to be ill. And I think when we think about how we're going to be self-sufficient, how we're going to manage ourselves, then we need more money going into research, not just in healthcare, but for example, in the basic sciences. So I'm quite sure that very many of us, and I ask this even amongst my students, couldn't point out a virus if they met one. So we're talking about things that people really don't know what it is, and that goes to our sciences even at university level. So people are familiar with the bacteria, but you see the way in which we manage things like cholera, we're still not even good at that level of stuff before even you move to sort of high-tech virus and so on. So right now the government could put in money into research money into basic sciences at university level to improve our diagnostic capacity, improve how we manage our environment and how we control our environment. I think that will be a step in the right direction. Now, the point I was making about actualizing devolution is that currently there are some counties that are doing very well in terms of allocating resources. So if you remember, we had envisioned that counties would devote at least 35% of their budget to health. Now, the average is about 27%. There are some counties like Nairobi, which are just bad news in terms of the amount that they allocate per person. There are some like Machakos or like Kipia or Muranga that are doing very well relative to the others. And so those governors, there's something that they know, and at least they're trying to do stuff. And the other governors who are totally asleep. So it's very hard to hold to account an amorphous thing like Ministry of Health. It is way easier to hold to account governors at a lower level. And the final thing I'll say about that is that we also need to professionalize the health sector. And by that I mean we've evolved with time. The doctor in charge of health used to be called the medical officer of health, or the chief medical officer. With time, it's become part of the general bureaucracy, so there is no professional accountability. And so the person who is currently there is called Director General. It could be the Director General of anything, rather than Chief Medical Officer. So I think if we go back to that, where you have that accountability to what Dr. Bosire was saying, where you know the doctor person and the doctor knows you. And to me, that should be the image that we should have. Thank you.
Okay, some really great responses. And I really like what you said about research, because I think that's a fundamental thing we haven't yet talked about. We have a wonderful number of questions, and I'm going to go straight to the questions. I know we started a little bit late, but I do know that there are so many questions, so we're going to try and get through as many of them as we can. And ask each one of you, pick a question. I'm going to read 2 or 3 and then come over to you. Is there, what would you say about role model countries, model healthcare systems. Leila Mshai is interested in knowing, are there models that we can look to? Do we have any case studies of dynamic collaboration and genuine choice between the public and private health care providers as we think about how we can grow our own? There is a question on devolution, and what recommendation could we give to the Ministry of Health to address the question of inequality? I know you've said a little bit about that already, but Winnie, maybe I would like to know if there is something else that you can give. And then again, going back to our model countries, is there something in particular that India is doing that we can learn from? Does anybody want to answer any of those questions to start with? It's very brief.
Maybe if I will take the question of countries we can model from, I think looking at universal health coverage, success story of Cuba, I think, has been told over and over and over again. But also Cuba is one of those countries that outsiders don't really visit much. And when you visit as a tourist, you don't get to see what happens in the healthcare system. As we speak, we have 50 of our own doctors in Cuba currently undergoing studies in family medicine right there. And having looked through the system and what they teach and they entrench, it really does foster what I was talking about. That primary healthcare is so deep in that country that every doctor graduates from medical school and first becomes a primary care physician before they can specialize further. And so the way the country runs is such that every doctor is allocated a number of households. You take care of those households for the entire duration of your work. So you wake up every week, you start by seeing those who need to be seen in clinic, and there are days you do community visits and walk door to door, see them at home. You actually have a family tree of these people. You don't just look at them as an illness. You also understand the socioeconomic factors. You know which household has a teenager with an unplanned pregnancy. You know which household has a child whose vaccination has been delayed because of a medical condition. And you know which family is hit with which hereditary condition that is, going to recur because it's a genetic problem. And this then enforces this very personalized care. And I will tell you that, do Cubans live healthier than we live in Kenya? No, they don't. They actually eat much poorer than we do. They have a much higher rate of diabetes and hypertension because of their diet. But do they die as badly as our own patients do? No, they don't, because they have been incorporated in their own care from the time this illness has set in. So they will live longer with a better quality of care. We can model on that. If we go to Thailand, we're going to look at this. Why was Thailand's UHC so successful? Because they started by involving the actual implementers at the policy level. The way we tried to implement UHC in this country is such that policies were made and then handed over for implementation. And you're telling people to implement, but you didn't ask if this works for them. So in Thailand, they started with the highest level of decision-making in the clinical setting, which was the doctors. And I said, look, you're not going to achieve UHC sitting in big cities, wanting to deal with a small population of well-off people. Show us what you can do by going out there and working in the rural communities and improving health for them. And this has worked really well. So they have motivated these healthcare workers. They have given them a lot of reason to want to sit there and succeed. And they reward this success. And these doctors are probably even better paid and better remunerated than the doctors who work in the city. They become committed to the communities they work, and this is something that we can model. We want to work with community health extension workers who we do not want to include in the system. We don't want to remunerate them for the work they do. So how is someone important when they're giving you free service, but we don't want to look at them as they actually are part of the expenditure for delivering a useful healthcare system. So I think those are some of the examples we seriously have to look at, we have to learn from, and we have to learn how to embrace teamwork and proper referral mechanisms for us to achieve that.
Excellent, thank you very much. And I think the question also on how we address the question of inequality, I think it's something that you've already begun to answer, that by paying attention to that, the question of whether people's social class, whether people have money or not, that is going to be, it already has been addressed. And I think even when the question on India, I think you've begun to answer that some of those questions, some of these countries have paid attention to some of the things that we have left behind. I want to go to another question.
Maybe if we'll just add on the India story. And I think one of the things is, again, I have said, communication, communication, communication. India went into a very concerted effort to market their country as a healthcare destination. So just the same way we tout our tourism sector, we show off our beautiful animals. And when the tourists come here, we give them first-class treatment in the hotels. Our safari drivers are very polite and courteous. This is what the Indian health workers did. So when you come in, you're made to feel so important that it doesn't really matter whether you're going to get well or not, you feel cared for. We need to bring that into our system where, as much as we're educating our doctors to be very good scientists, they have to be human. They have to learn to talk to their patients and treat a patient as a wholesome human being and not just a condition. And when we can be able to achieve that, I think we will just understand what's so attractive in India.
Thank you very much. Dr. Masese, Joy Mboya is looking at the question of communication and is asking, effective communication and information dissemination is such a challenge. And so how do you resolve this in your vision? Is the question digitizing? How does this whole new digital space play in this regard?
I think communication is very important for our health. But you should know that when you talk about like universal health care and communication, we use universal language. And these people are not just mere consumers of information. They synthesize that information in relation to their socialized context and then interpret. This interpretation is what informs their subsequent actions. And therefore, to us to succeed, and I want to combine this question in relation to the devolution recommendation so that I can bring it in. I tend to think the best way we can do is we try to contextualize our communication to the target communities. And this can be done by the devolved governments. For instance, if you talk about COVID-19, and we are using the same language which is used by World Health Organization, when it comes to our communities, we try to look at this COVID in relation to our ethno-medical systems. For instance, we see COVID, though a very dangerous disease, we see it as a common flu because we have been socialized. One, it has no medicine. You can only heal through medical support, the same as common flus.
Yes.
And therefore, we cannot act by what we are supposed to be doing. So in this case, I tend to think that this idea of universalizing communication should not be the case at this moment or in the way forward. And therefore, it has a very big implication on our healthcare systems for the Ministry of Health. I think the Ministry of Health should come up with us, or the government should come up with a sign that preventive or promotional preventions should be done by the devolved governments, where they will deal with primary healthcare issues. And cumulative will be done by the national, because more universal.
Would you say that digital strategies would be a good way for the county governments to proceed?
Digital, let's look at what has happened with the COVID. We have been having digital messaging, and what has happened? It has created a major crisis for us. It's actually, they are calling it infodemic. So in this case, this digital should also be contextualized within specific target groups if we have to succeed.
So it needs to be a much more holistic way of looking at communication. Dr. Ayah, the question of mental health If we look at how many people are not part of our healthcare systems and how many people have just stopped going to hospitals, Dr. Abuya is asking, can we say that Kenyans are psychologically and mentally stressed and we need to pay attention to mental health when we think about this vision and where we need to go?
I think we do. And I would broaden that question a little bit, because one of the, I mean, just to go back a little bit, the thing about communication is that, for, you know, health is, a lot of health is a conversation. So it's not a one-way thing where, as Dr. Bosire said, it's not a one-way thing where you say and then somebody just receives. It's supposed to be a conversation. Yeah. And so we've got fairly limited systems in terms of explaining mental health. I know I struggle trying to explain, even if you just translate, I think you just get mad and not mad. So even translating medicine into mental health terminology so that people can understand is quite difficult. So in this case, we're already a fairly highly stressed society, given our economics and everything, and then adding this on top. So I think it is an issue, and it's one which we're in trouble with simply because we just don't have the capacity or the language or the means to be able to translate how we should manage it.
Yeah. Okay. And I have one as I come in and ask you to make your final comments. Actually, Yvonne Awar has two questions, but I want to combine the two. She's asking, what would it take to establish a world-beating research medical facility with county hubs in Kenya and turn this country into a world reference site for medical research, treatment, and medical innovation? And she's asking, is there a way that we can incorporate knowledge gained from centuries of those we call traditional medical practitioners as we think about a facility like that? So to any of you, what would it take to do this?
Is that a 2050 question? Or is
yes,
it next week?
However,
yeah, I mean, you know, we have some of the best researchers globally recognized in this country, particularly around HIV. So already we have some people who are very, very good and they're renowned. So it doesn't take very much to, I mean, they're there to publicize that. However,
that's next week.
Yeah, so however, we're very thin on the ground. So we don't have that community of practice. And I think one of the tragedies that we have in this country is, you know, the private sector does not report to the public, to the Ministry of Health. So I'm going to say something that's a little controversial. For example, you know, our doctors are overpaid, you know, relative to how doctors are paid across most of Africa, and has been mentioned, Cuba and all that. So, and that's because most of them are in the private sector. So there's that comparator that if you're in the public sector, why would you stay when you should be earning more in the private sector? And yet the private sector is taking care of only about 10 or 11% of Kenya's population. So in terms of trying to create that world class, that's part of what has to be corrected in a way so that Kenya is not competing within itself. Yeah.
Okay. And these are just such great insights. I'm really sorry that we ran out of time because I have a million questions. I can see from the chat, for instance, there is some pushback on the examples of Cuba and India. And I think the great thing about that is you've offered us some examples, and then people are saying, okay, we want to talk about this. We want to think through this. Are these really the models that we want to go through? Can I
just add very quickly two more examples on that? Because I think Cuba is fantastic when you think about the human resource.
Mm-hmm.
Taiwan is fantastic when you think about how they manage their money. They're extremely efficient. And Germany and South Korea are very good when you think about how they're able to mobilize communities to pay for healthcare.
Okay.
I think you have to pick from different countries.
Gosh, I think we could have an entire webinar and just go through model after model. But the important thing I'm hearing is that the models exist. And we just need to think about how do we adapt them and how do we take them forward. I like the comment by Boaz Otieno Nyunya, who says that health must be viewed as an essential commodity. And if we start to think about that, if we really think about what does it mean to put health at the center of our systems, if we think about ordinary people at the center of what we do with health, we start to move forward. I can take like one comment from each of you as we close. I'm grateful for the many insights that you have presented, but what is the last one word that you would want to leave with each one of us? The one thing that if we forget everything else we've said, this is what you must remember. Dr. Masese.
I think I would just comment that to make our health system world class, we just need to do one simple thing.
Yes.
Humanize our healthcare systems through multidisciplinarily, interdisciplinarily, and interdisciplinarily. In this case, let's inculcate the values within our health systems. It should not be seen as a medical practitioner or those who are medically professionals. Let's bring sociologists, anthropologists, historians in the systems. And what Dr. Ayah said, like you bring even the people who are dealing with the traditional medicine, put them together, then that's why we can have this holistic way of doing things. And that's why I think what Dr. Bosire said, if you go to India, people feel like when you go there, they are courteous. So you can put the value, first of all, the ethics, then you go to interdisciplinary way, our healthcare system will be the best. And I'm looking forward after this COVID, that's the way I think this will go.
Thank you very, very much. Dr. Ayah, what would your last word be?
I think, I'm trying to think about how to put that as the last word. For me, it is to say, if you can't buy health, you can't buy good health. Health is something that is community, is something you find in your community. So the idea that you can have good health and the person next to you does not is a myth. And therefore, it's one of the primary functions of government, and therefore we have to hold government to account in terms of providing good healthcare. You can't opt out and buy all the insurance you want and hope that you'll be okay.
Okay, that's such an important point, that we can't buy health. And we know people who get very rich, and then at the time when you need it, you realize how important healthcare is and good health is. Dr. Bosire, what last?
My last comment is really simple. There is no such thing as rich or poor when it comes to quality of health. And we can never truly claim to achieve universal health care if we cannot standardize the quality of care. It doesn't matter where you seek care in this country. If the same exact quality can be offered across board, whether it's a public institution or a private institution, then we will have actually achieved universal health coverage. It's not just about being able to access a hospital, it's about the quality of care that you get there. And that's what we keep making reference to. We don't want these shortcuts called poor medicine for poor people. We want solutions that are actually wholesome, that dictate that every Kenyan has a right to access health as envisioned in the Constitution, that has exact same quality. So what the president gets, I expect the mama from Kibera to get, and that would truly be universal healthcare.
Mm-hmm. Thank you very, very much. I'm looking at some of the comments that people are giving us, and there is a lot of engagement with what you are saying. The question again that, let me just pick a couple that so far, Nuramed is pointing out that COVID-19 has been more of a government project than a community-owned thing. So the thing that you've been telling us, that we must make health something that all of us think about, something that all of us are able to engage with, is really important. The question of that you brought up on gender-based violence, as really being a healthcare issue, and saying that this is something that the health sector must think about very seriously, and that we need to even perhaps think about it as a department on its own. We have a comment that, okay, I just lost one of those that I was looking at. The question of inequality and the way inequality has really become clear, that inequality in health investments in some of the different counties, and how we must pay attention to resolving that. And as we go to the end of this, I just want to point out that next week, as we continue to think through what Corona is teaching us, we will be looking at some of these questions. The next Corona Café is actually going to be thinking through the question of inequality, and we invite you to come and join us as we think about the deepening inequalities. We're really going to be focusing on the idea of a case for social welfare and how we can eradicate these social inequalities that we have talked about and said how important it is to resolve. We will be looking at the question of reimagining education, again, going to this educational divide, and we know right now the country is waiting to find out what is going to happen. And then we will come to the question of Africa's contribution to redefining a new economic reality, because we've gone back to that question that so much of the impact that we are facing, yes, there is an impact to our health, but there's also an impact to the very way that our societies are structured and what we have learned about that. I really, really want to thank Dr. Eric Masese, especially for bringing your insights on how society needs to rethink how we look at health from a social perspective. Dr. Ayah for bringing in the insights, particularly from a public health perspective, but also helping us think through some of the issues we have to do with research and have to do with the disparity of our healthcare system. And Dr. Bosire for some of the excellent examples you've given us of countries that are working to put the patient, to put people at the center of the health question. Thank you, everybody, all the participants who've asked questions, who've given us comments. We look forward to seeing you as we continue to talk on our Corona Cafes. Thank you very much. I don't know me,